Okay, let's start. It's 4 p.m. Central European Time. It's time for the webinar from ERN Reconnect to our patients, to our dear patients, and it's really a great honor and a pleasure for me to moderate this webinar devoted to pregnancy and the antiphospholipid syndrome. I am Ricard Cervera from the Hospital Clinic in Barcelona, working for many years on the antiphospholipid syndrome with close connections with patients associations, and it's really marvelous to have here two unique speakers to talk on this. We have Silvia Aguilera, which is from SAF Spain, the Federation of Patients Associations of the Antiphospholipid Syndrome in Spain, and also one of the leading patients, IPACs, at the ERN Reconnect. And she herself has the antiphospholipid syndrome, so he knows very well this story. And also we have Angela Tincani. Angela Tincani is one of the mothers of the antiphospholipid syndrome. She comes from the Spedali Civili di Brescia in Italy. She has been working on this disease since the very beginning, since the discovery, since the definition of the disease. And it's really marvelous that we have her in this webinar. So all together, I am sure that we'll do an excellent presentation on the management, on the things to keep, or the message to keep for patients regarding pregnancy and the antiphospholipid syndrome. And before they start their presentation, just some domestic informations. This webinar will be recorded and then published, so you can have the opportunity also to vision again this webinar. It's very important interaction with people attending this webinar. And for questions, you can use the question and answers bar, and also the chat that is in this Zoom, as in all the Zooms. And the questions will be addressed to the speakers after the presentation. So you just put your questions in these places, in the chat or in the Zoom black bar. I have seen that there are already some questions, and we will put these questions at the end. So really, it's marvelous to moderate this session, and I think that Silvia and Angela, the podium is yours.
Thank you so much, Ricard. Let me share my screen.
Good afternoon, everybody. While Silvia is starting, I am happy to be here with Silvia and have a nice webinar. Hopefully.
Yeah, thank you so much. On my side, I just want to say it's such an honor to be here with Professor Cervera and Professor Tincani as a patient, to be doing a webinar with them. It's such a pleasure, and I'm sure we will have a lot of fun today, and we're going to learn a lot. So today we're talking APS and pregnancy. And when we have APS as a patient, we have so many questions, and we know that when we ask other patients and when we share with other women what treatment they're having, and then we start having even more questions, and then you talk to someone and they tell you that they are taking a heparin, and then you're wondering why you're taking a different heparin, or someone tells you that they started aspirin and you started aspirin at a different time. You've heard about preeclampsia, eclampsia, or maybe you are having troubles getting pregnant, or you want to know if you can do IVF. So we're going to be covering all of this. But before, I would like to start with Angela, that she will start telling us a bit about actually what is obstetric APS.
Thank you, Silvia. So obstetric APS was defined in the international criteria, and if you go on, yes, before the international criteria, we understood that many of us understood that connected with the presence of antiphospholipid antibodies, there were great pregnancy problems, pregnancy loss and pregnancy pathology. And this was a great achievement for many, many women. So here you can see a series of pregnancy in 200 patients. And there are on the left, the anamnestic pregnancy, the pregnancy before the diagnosis of obstetric APS. And you see how many losses there were, 72%. And after the diagnosis in the prospective followed pregnancy, you can see that 88% ended, 88% of the pregnancy ended in live birth. And this was thanking all the knowledge that we got through the study of this disease. And one of the first things was to work together with our colleague obstetrics and gynecologists. And this was the time in which we started. And I had in this slide, I show you the first obstetrics that in Italy looked after this pregnancy, Dr. Faden, that died years ago. But I think that he also was one of the first in Europe and possibly one of the few in the world looking after this pregnancy from the early 90s. So this is a great success of medicine. Shall we go on? And if you want to see in detail what is obstetric, what was defined as obstetric APS, was defined as one or more unexplained death beyond 10 weeks of gestation in a patient with antiphospholipid antibodies, or one or more premature births before 34 weeks of gestation because of eclampsia or preeclampsia, or because of placental insufficiency, or 3 or more unexplained consecutive recurrent miscarriages. All of these in the frame of a patient with a substantial positivity of antiphospholipid antibodies. Can you go on? What have we done? What can we do with this disease? This was learned through the year, but not a long time ago, in 2019, were delivered the EULAR recommendation in which Ricard, Cervera, and I, and many other colleagues, including Marta Mosca, worked together to give to the patient the most clear setting of recommendation to give to the doctors and therefore also to the patients. So Silvia, you can go on.
Just to say that to the patients here, that to stress again that we are so lucky to have here Ricard and Angela, that are the ones authoring these kinds of papers, as well as many other Reconnect and other colleagues that are on the paper. Such a pleasure to be here. So from a patient perspective, we obviously right now everyone wants to be informed, and you can Google the paper. The recommendations are open. You can find the PDF and you can read them. But let's slow down a bit and let's learn how to read the EULAR recommendations. So the recommendations are summarized in a table. And if you look at this table, you will see statements, yes? And then you will see LOE, GOR, LOA, and we're going to learn what this means because not everything is at the same level of recommendation, okay? So just very quickly, don't worry, there's a lot of information here, but we're going to concentrate on what is important. The level of evidence is going to tell us what kinds of studies are giving us this evidence. This is the pyramid, okay, of the different types of trials that give the level of evidence, okay? This comes from the UPATI Patients Academy of Therapeutic Education, and this you can find, there's actually a module that you can see down here that you can learn about this level of evidence. So you can see that it's defined in different levels, and then you have level 1, level 2, level 3, okay? So just that there are different levels of analysis, okay, that you can do, and we will see now what this means. So you see that there's level here, level 1 to 5, and then level 1 trials have higher quality evidence, and the ones at the bottom, level 5, have lower quality evidence, okay? So then when you go back to the table and you see the statement, and you look at the level of evidence, LOE, you can see here that, for example, we have statement 8 that has a level 5, and now we know that that's the base of the pyramid, so it has a low level of evidence. And for example, statements 9A and 9B, which have high level 2B. So we know this is a higher level of evidence, okay? Great. If we continue, the GOR, what does this mean? So this is the grade of the recommendation. This is the same. Based on the pyramid before, we know the levels, and then this is just grouping the levels. So we know that A has a highest level of recommendation by grouping the level 1 studies, the level 2 and 3. So A has the highest level and D has the lowest level. So when we go back to the table, we can combine these two, and then we have the level of evidence as well. So we see that 5D, for example, for statement 8 has a lower level of evidence than statements 9A and 9B that have 2 or B, okay? The last thing we need to learn to read the recommendations, the level of agreement. This is super interesting. So the level of agreement, it shows us the numbers that indicate the experts that have been on the paper, how much they agree with the statement, okay? So how does this work? So the experts get the statements, okay? And I've taken here 2 examples. So statement 8 and statement 11. And then they ask the experts here, so I've put our experts that are here, how much do you agree with the following evidence? So everyone gives their grade, like for example here, Laura agrees a lot with statement 8, and so does Natalie, but they agree a bit less with statement 11, sorry, okay? So what happens then? We calculate the average, okay, for statement 8, and then we see that there's an average of agreement of 9.3, and we have the standard deviation, which is just an indication of how spread this data is, of 1.5. However, if we look at statement 11, we can see that the average is higher, so they agree more on statement 11, but not only that, the standard deviation, or how wide the curve is it's thinner, so it's a bit a sharper curve. So this means that they agree more between them, yeah? And you can see this here in the table, for example, because you can see that I put here that Elizabeth, for example, for statement 8, she only gives a 7.6 to statement 8. And so we have a spread of the data between 7.6 and 10, while for statement 11, we have more of an agreement. Everyone gives a higher grade. So there's less dispersion. So there's more agreement between the experts. So if we go back to our table, now we can read completely the table, and we know what all these numbers and letters mean. And we can actually see that sometimes when we, as a patient, we get a paper or recommendations, and we wonder why our doctor, for example, has not recommended a specific thing for us, we can dig a bit deeper and see that maybe even between experts, the agreement is not the same, or that the level of evidence is not very high, and that it is something that it is still in discussion. So just to summarize, this is very important because not all the recommendations have the same level of evidence. Each patient is different. So your doctor, there will be recommendations that are clear, that are beneficial and good for everyone, but others, there are still discussions and there still needs to be more evidence about them. And it is not a problem if your treatment is different from another APS patient according to your medical history or personal needs. So now that we know how to read the EULAR recommendations, what we have done, and this I have to thank SAP España because this is a work I did with them. We did this flowchart of the recommendations to make them easier to read. And this actually is part of our patient education when we onboard APS patients to the association. And then we're going to be reading a bit with you the recommendations, and Angela will be telling us the difficult parts of these recommendations. So we will start having a conversation together. So if we look at statement 8, remember statement 8, high-risk antiphospholipid profile antibodies, no history of clots or pregnancy complications with or without lupus. The recommendation is to have low-dose aspirin during pregnancy. But Angela, what does it mean to be high-risk antiphospholipid profile?
So, to be high-risk antibody profile means, first of all, to have lupus anticoagulant positive. These can be positive alone or double positive, so associated with anti-beta 2 GP1 or anti-cardiolipin antibodies, or triple positive, associated lupus anticoagulant associated with both anti-cardiolipin antibodies and lupus anticoagulant. And also these antibodies should be persistent in time. So during months and years should be always high titer, always consistent results. While medium to high is considered a profile not including lupus anticoagulant, but including reasonably high titer of IgG or IgM, anticardiolipin or anti-beta 2 GP1 antibodies. Low risk is considered a low titer with intermittent positivity also. So a patient that is positive and in the second determination is negative, but then is positive again. This is considered a low risk. But now I have to tell you something that we are struggling since decades, and Richard knows very well. That is very difficult to say low titer, high titer, medium titer, because all you see here, and by the way, all you will see in the new classification criteria of APS is related to ELISA test. And nowadays, it's very rare that in a hospital they perform an ELISA test. So is something that is upsetting me very, very much in these days, because I remember what happened 30 years ago and is not much different. Having said that, I trust, to me, the patient really high risk are those with the connection of the 3 antibodies. The triple positive are really at risk patient independently by the titer. So
perfect. We're looking forward to seeing this updated classification criteria for APS. Great. So we go next to statement 9. So the recommendations say, if you have a history of obstetric APS only, so no clots, no other history of APS, if you have with or without lupus, if you have 3 or more recurrent miscarriages before week 10, or you have a history of fetal loss over week 10, the recommendation is low-dose aspirin and heparin at a prophylactic dose. Angela, what does this mean? What is this heparin, MWH? Explain to us. Let's start with what is the difference between these 2 kinds of heparin?
Okay. So as the word says us, unfractionated heparin is a bigger molecule and low molecular weight is a smaller molecule. But unfractionated heparin is the old one, target two coagulation factor, the 10A and the thrombin. It is very quick in its action and can be used also in patient with some problems, some complex problem, like patient with renal impairment. Low molecular weight heparin is a smaller molecule the molecule target only one coagulation factor, that is 10A, is more easy to take because it's a longer half-life, so you can do less injection and have the same effect of unfractionated heparin with more injection. Is more bioavailable and have a lower risk of unwanted effects, especially the heparin-induced thrombocytopenia, that is a very frightening side effect of heparin. But there is a problem, at least in Italy. I think in Spain is better, I don't know. But at us, this low molecular weight heparin has an high cost. And so for prophylactic reason, they don't allow us to use it. And we have to use unfractionated heparin. I don't know, I hope that in Spain is better, but in Italy is like this. Then if you go on, we can see.
Let me save my PowerPoint. Yes.
Yes.
It's because you said prophylactic, Angela.
Yes, prophylactic. The prophylactic use is just what you have seen in the recommendation. So for patients who never had miscarriage and never had thrombosis before, and the prophylactic dose for unfractionated heparin is usually 5,000 international units twice a day or 3 times a day, depending on the body weight and many other things. For low molecular weight heparin, could be 4,000 once a day or 2,000 once a day if the patient is very thin. Therapeutic dose is generally higher. It depends from several things, including the weight of the patient, including the event that that happened before: arterial thrombosis, venous thrombosis, myocardial infarction, whatever. And in this case, we can have unfractionated heparin at 15 or 12,000 units twice a day, and the low molecular weight heparin 6,000 units once or twice a day. So this is basically the story of therapeutic dose for those patients who already had thrombosis or a kind of thrombosis, and prophylactic dose for patients who never had thrombosis and never had fetal loss.
Perfect. So very important. There's 2 types of heparin. So, and not maybe 2 different pregnant women will be taking different kinds of heparin. This is completely normal. And not everyone has the same dose of heparin, and it depends on your weight, on your medical history. So don't compare yourself to another patient, and do not worry, your doctor is thinking about the dose that you should be getting. More questions. It said aspirin as well, Angela, low dose aspirin. What is the deal with low dose aspirin?
Yes, low dose aspirin is very important in pregnancy, in obstetric APS, because low dose aspirin is an aid for the fetus. It allows a better fetal outcome. Some of us started at positive pregnancy test, some of us before 12 weeks of gestation, and the obstetric say before 16 weeks of gestation. So nobody knows what is the right answer. To me, it's better to start before pregnancy. This because when a patient gets pregnant, usually she gets sick. She started to have a problem in her stomach, she vomit and so forth. And since low dose aspirin can affect the gastric apparatus as well, I will not know if it is pregnancy or aspirin to get the patient vomiting. So I prefer to have aspirin in a quiet period, and then the patient is already used to take it, and she starts pregnancy. Maybe she starts vomiting, but it's not aspirin, I know. This is the reason why I prefer to do it before. I don't know if
yeah, but
makes sense.
We saw already that the level of agreement on this particular statement was not particularly high, because the evidence also was not very high quality. So obviously there is a debate around this, and I'm sure you will talk about aspirin after again, Angela. So we will talk about aspirin again after, because there's a part 2 of aspirin. Great. So if we continue with the EULAR recommendations. So we are on statement 9. You have a history of obstetric APS only. You haven't had a clot. You might have or not lupus. And then you have had eclampsia, preeclampsia, or placental insufficiency before 34 weeks. And then we have here the recommendations that actually your doctor will assess your risk profile. And the core recommendations are either aspirin or aspirin combined with heparin in a prophylactic dose, which now we know what that means. But Angela, what is eclampsia and preeclampsia?
So these are problems of pregnancy, not specifically of APS, but antiphospholipid antibodies can favor preeclampsia, so can be a predisposing factor of preeclampsia. Preeclampsia is defined as a new onset hypertension and proteinuria, together, sometimes not always, but often connected to other organ damage, such as damage to the liver or the brain, occurring suddenly after 20 weeks of pregnancy. And eclampsia is the occurrence of seizures in a human with preeclampsia. This is the definition. The common symptoms of preeclampsia, so what feel a patient with preeclampsia? She started to have headache, usually, vision changes, tinnitus, epigastric pain often, and often edema. So she started to gain weight. And of course, the blood pressure will be high, and the protein in the urine are high. If you go to the next slide, we can tell that the main problem of preeclampsia is that is a pathology of placenta. Is something that affects the normal placentation through the change in the at vascular level. And this change at vascular level can affect all the body. So this is a very serious complication. And as you can see, antiphospholipid antibodies, together with other chronic problems such as diabetes or obesity and other things, can favor the development of this complication. Also, the disease, some disease like lupus, as an example, these are situations in which we have to look carefully to prevent preeclampsia, and again to prevent preeclampsia and favor the circulation in the uterus and in the placenta, we have to use low-dose aspirin.
Perfect. Great. So we continue with our journey through the EULAR recommendations. Last part of recommendation 9. So remember statement 9, history of obstetric APS without previous clots, with or without lupus. I have seen that we have some lupus friends in the audience, so they will be they are also in these recommendations. So Statement D, non-criteria obstetric APS treated with prophylactic dose heparin during pregnancy. And then the recommendation is to continue for 6 weeks after the delivery. But what is non-criteria obstetric APS?
So you remind what till now we consider criteria obstetric APS. With the new classification criteria, something will change, but by now we consider 3 or more unexplained consecutive spontaneous abortion. But if the patient had only 2 spontaneous abortions, what to do? She she has antiphospholipid antibodies, but only 2 miscarriages. And this is a non-criteria or incomplete, as we used to say years ago. Or if a patient had preeclampsia with delivery of a premature baby and so forth, but it was after 34 weeks. So what to say? She has a non-criteria obstetric APS, but there is another situation, a situation of a patient with 3 miscarriage or with 1 fetal loss, but with very low antibody titer, or antibodies coming and going, not stable antibodies. But this is again a non-criteria obstetric APS.
Perfect. So maybe these people are also in the recommendations for some of the cases. Great. So we continue. Okay, we are arriving to the end. So this is just like the final statements. Statement 10, criteria. So Angela just explained to us what criteria IPS. Remember what are in the criteria that is well established. So criteria obstetric APS with recurrent pregnancy complications despite, so we're taking aspirin and the prophylactic heparin, and this is not working. We're still having problems. So we have these options that you can see here, that you can see that they have a lower level of quality evidence. So or when they did the recommendations, because this in very little time, there's been some studies and things have changed. So either to increase to therapeutic heparin dose, which Angela has explained before, we can add hydroxychloroquine, add low-dose prednisolone in the first trimester, or intravenous immunoglobulin in highly selected cases, or these are the recommendations for this. If statement 11, you have a history of thrombotic APS, recommendation is low-dose aspirin and heparin at therapeutic dosage. Great. So this, we did this with the EULAR recommendations because a lot of the questions that patients have regarding pregnancy and treatment are actually covered by these recommendations. And I think it's useful as well for patients to know that these recommendations are there, and it's where the doctors go to see what they should be doing. And I think that the patients should also know that this exists, so they can go there for a reference and they can know how to read them. So we have covered a lot of questions that we normally receive in patient associations, and I guess that doctors as well. And now, what happens with all the topics outside the recommendations? Well, like what we were saying, what are non-criteria, what happens with the hydroxychloroquine that we just saw, that is just, it was in the recommendations, it's just advised to take just in very specific cases. So now, Angela, I give you the floor so you can start talking about all the extra things that are not in the recommendations.
Yes, but before starting, I just want to stress what you are saying, what you said already. I think all the patient has to be aware that most of the recommendations have very low grade because there are not randomized controlled studies. And this is for many reasons. One reason is because APS is a rare disease. The second reason is because in pregnancy it's very, very difficult to do a randomized controlled trial. So most of the recommendations come from the joint opinion of people who worked in the area. So maybe your doctor is thinking something different, but he is not wrong. This is important to know and to remember, because for many things, nobody knows where is the real truth, where is the evidence-based medicine.
Trust your doctor, and if you don't trust your doctor, ask your doctor questions, because I'm sure that doctors, if you are pregnant and you talk to another pregnant APS patient and you're not sure about your treatment because someone else has a different treatment, talk to your doctor and ask them why you are getting that specific treatment, and trust your doctor. Yes. This is my main message.
Yes, yes, I agree totally with you. So the story of hydroxychloroquine is very nice, because it was shown in mice, in rats, I think, that anti-beta 2 antibodies are cleared from the circulation, and they are found around the fetus of the animals. But if you give the animals hydroxychloroquine, these antibodies will not go around the fetus, so will not affect the placenta and will not affect the fetus itself. So this was shown in the animals, and this is very interesting to be applied in the patient. And if you go to the next slide, this is also very interesting, because it's a study done by a colleague that works in Padua, and she collected 194 pregnancy in patients with primary APS, and she could show that not only, if you go a little bit, because there is a list of not only the first one, but not only as was shown by other authors, hydroxychloroquine could help a better prognosis of the pregnancy, of the next pregnancy, but also, and if you go to the other piece of slide, there was a dosage, a little higher dosage that the one that we are used in not pregnant patient, with 400 milligram day, started before pregnancy. This could be a very good option for patients who failed to carry on a successful pregnancy using the combination treatment, so using low dose aspirin and low molecular weight heparin. So this could be an interesting option for patients who failed, who had a refractory obstetric APS. So there could be other, I think there could be other strategies. However, this is an interesting strategy. And if you go to the next slide, probably for all these observational studies, not randomized, but observational studies, also the European Medical Agency has recognized that hydroxychloroquine is a drug for the treatment of the antiphospholipid syndrome. And this is important in some way, because this is an orphan drug. Nobody will pay a randomized control trial for hydroxychloroquine, but hydroxychloroquine is something that is probably useful in the antiphospholipid syndrome. And the last word I want to leave you is for the assisted reproductive techniques, because many patients now think to do this procedure because they do not succeed to have children, or they wait too much, sometimes not for it is our fault, the fault of the doctor, not of the patient, because sometimes we say, oh look, you have to wait when your disease is under control, and we never say when the disease is on control. So sometimes it's our fault. And the patient, I see more and more patients who go to see doctors looking at assisted reproductive techniques. So I must say that in our experience published some years ago, it was not particularly problematic for patients with lupus and or antiphospholipid syndrome. So there was a good number of live births. We had a few neonatal deaths, unfortunately 4, and mainly there were because of severe prematurity. And the prematurity come from the intrauterine growth restriction or PROM. That is not really clear if it is linked to APS itself or to the procedure, in which, of course, in this kind of things, the pregnancy complication is higher. But this is not the experience of rheumatologists, but of obstetrics. And also, not only we had this experience, but if you go to the next slide, also in France, they did a similar study, and also for them, the outcome was good. Regarding maternal complication, they are not frightening unless the patient do not follow the advised treatment. So it is okay for the mother if she is taking her anticoagulant and anti-aggregant treatment. Also during the procedure of uterus or ovarian stimulation, they have to take low molecular weight heparin at a recommended dosage according to their pathology. And nothing will happen. But if a patient stop the anticoagulant treatment, the thrombosis risk is very, very high. So be careful to be well cared while you are doing in vitro fertilization procedures. So this is what we have prepared for answering questions that are very frequent. So we don't know, you may have other questions, and we are here to answer. And thank you very much for your attention and for being here.
Yeah, we have 43 participants, yes.
Excellent, 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 Angela. Tanta grazie. Silvia, muchísimas gracias, moltes gràcies.
Gracias.
This was really a marvelous webinar. I enjoyed very much, and I learned also a lot because you explained so well everything I hope was very clear. Probably people will put additional questions. For instance, there are several questions, both in the bar and in the chat. Somebody is asking, you were giving or you were mentioning the recommendations for the doctors, how to treat this, but how to involve the partner or the family or the caregiver during the pregnancy. What is your opinion?
This is difficult because it depends. When you are sitting in your pregnancy clinic and for the counseling come the patient alone, you cannot involve anybody. If they come, two of them, so is better. In case the patient came alone, you can give her a booklet or some printed things to carry home for the partner. Or you can show some website in which also the partner can be informed. But if he does not come, maybe he does not want to be informed. I don't know. It's difficult to understand. Sometimes he cannot because he works. So if you give a booklet or instruction, he will see.
I think it is important for the patient to understand well the disease, so you can communicate well with your partner what the disease involves and what can happen, because there are risks when you have APS and you get pregnant. And if both of you know of the risks that are possible, then if something happens, you will be able to react better, let's say. There's also many patients that say that, for example, they need help with injecting heparin because it's sometimes, it's not a nice experience. And actually there are some caregivers or partners that do inject heparin to their partners, so they can be involved in that. They can help making sure that you are taking the medication, that you have support in that. And I can talk about my personal experience. So I have a classic APS with a clot, but I also had preeclampsia, and I knew, like what Angela explained in the slide of what you can get when you had preeclampsia, and because I was high risk, remember, high risk profile, I am high risk profile. So my doctor told me to measure my blood pressure every day. So my partner was always asking me if I was taking my medication, I was having my aspirin, my heparin, and if I had taken my blood pressure as well. And actually one day I had really high blood pressure at 24 weeks. And this is what made me go to the hospital. And I had my son at 26 weeks. And he's now okay, he's 4 years old. So it was a hard story, but it has a happy ending. But if I hadn't measure my blood pressure at 24 weeks, because I didn't have any other symptoms, and I had no other symptoms in the hospital when I was getting worse and worse with the preeclampsia. So possibly if I had not done that with the support of my partner, reminding me every day to do that, it might not have ended so well. So inform your partner about the illness. Inform yourself. If you don't understand it, ask your doctor, find a patient association. We are here for you as well. Explain it to them, and then tell them as well what you need. Like, I need you to I can't remember every day to take my aspirin. Remind me. Make them involved in the pregnancy. They can't know what you need, so make them involved also in what is involved in being pregnant with APS. This is my recommendation.
So it's very interesting. Very interesting, because you synthetically say that is the patient that has to inform the partner.
I think that when the partner already, you go to the doctor and your partner is not the one being pregnant, so they are already, like an attachment to the pregnancy, let's say, and they don't live it the same way. And on top of that, you are the patient. They can be there with the doctor, but you have to tell them how you are living the situation and what it means to live with a disease and how you feel having a disease and being pregnant. And this, the doctor cannot tell them. You need to explain to them what this is, the reality of this. Of course, make your partner go to the doctor, and they can ask questions as well to the doctor and their concerns. Of course, that you should always try to go to the doctor together. But I think it's a very, very big role of the patient to explain to the partner the reality of what you are going through.
So thank you, Silvia. This is very important for us to know.
Excellent, really. That's life experience. That's marvelous. There are some questions asking more specifically how some drugs are administered. For instance, you mentioned intravenous immunoglobulin. So probably, Angela, you can expand a little bit what are intravenous immunoglobulin, how these are administered, because these are not the typical tablets that patients receive.
in fact, you are quite right. They are not tablets. They are infusion. So there are different protocol of infusion. One lasts 3 days, one lasts 5 days, one lasts 1 day. It depends on what is chosen by the doctor who has in charge the patient. However, is an infusion that has usually that is usually done in the hospital, although nowadays there are also preparation that can be done at home, but in Italy at least they are not used for pregnancy, they are used for patient with immunodeficiency. So for pregnancy, our patient go to the hospital, come to the hospital and get the infusion. It can be done in a day hospital, doesn't not need to be inpatient, but this is what happened. And the preparation is a sort of pool of immunoglobulin from an enormous number of donors. And since these are antibodies, these are supposed to dilute your bad antiphospholipid antibodies, are not at the concentration of before, but they are diluted. And so they are less toxic for the cells. I don't know if...
Excellent,
Yeah,
excellent.
great explanation. Yes, that was great.
Yes. Also, people are putting more questions on other drugs. For instance, there is a question that was put even before you started giving your presentation, and I think that you already stressed the role of this drug, but maybe you can stress again. It's the role of Plaquenil or hydroxychloroquine or Dolquine, which is the usual brand name in Spain, in patients with antiphospholipid antibodies or the antiphospholipid syndrome.
As I showed before, the best randomized control trial was done in rats. Because in humans, there is a trial that is ongoing, but with great difficulties, I think, and I don't know where they are arrived. For us, in our country, is almost impossible to introduce pregnant patients in a trial, so we cannot do. But as I have shown in rats, the effect of hydroxychloroquine is to impair antibodies to reach placenta and to reach fetus and to fix a complement. So apparently this is a sort of very clever function of hydroxychloroquine. So in humans, we don't have randomized trial, we have observational trial, and it seems that increase the number of live births for pregnancy, and it also seems that decrease the titer of antibodies in the long time, and this maybe is useful also for patients suffering of thrombosis, maybe.
Okay, excellent. And there is another question on another drug that you didn't mention at all during all the webinar, and maybe it's because of some reason, is DOACs, direct oral anticoagulants, the new, relatively new oral anticoagulants. They are asking which is the role of these DOACs in the antiphospholipid syndrome or in the obstetric antiphospholipid syndrome.
I think the role is zero because unfortunately these drugs are not advised, are not recommended for APS and for obstetric APS as consequence, because they do not prevent arterial thrombosis substantially. These for patient outside pregnancy, but in pregnancy they are also teratogenic. So there is no role in this context.
Excellent. This is a very important clarification. And there is another drug or another therapeutical procedure that is mentioned here, plasma exchange. It is written here plasmapheresis, but those that know me knows that this is a wrong word. It's plasma exchange. Which is the role of plasma exchange in refractory cases with antiphospholipid antibodies?
Well, as you have seen from the recommendation, there is not a real rule for what to do in refractory patients. So there is somebody who has who is good in doing plasma exchange, and he or she does plasma exchange because they have the possibility and they have a good experience in it, and they know that clearing antibodies may be a good thing. There are other people who think to use Plaquenil or hydroxychloroquine. There are other people who think to use, at least in the first part of pregnancy, a little bit of corticosteroids. And this was also said that is useful some years ago, but still is something that can be done. I must say that I have used also statins in pregnancy. When a patient smells of preeclampsia and is not in the first trimester, I use statins, and it seems to work. It seems to lower blood pressure, and it seems, but is an impression because nobody has done. Well, there is one little randomized control trial published years ago, but nothing more. So there are many drugs that can be used when you are desperate. The good news is that very, very little patient is desperate, because most of the patient manage to have a successful pregnancy, I think. What do you think?
I think that after, sometimes it's a bit of a struggle because we have losses and there's no diagnostic. So sometimes it's until the diagnostic arrives, there are a lot of problems and losses. But once the diagnostic is there, I have to say that nowadays we have more and more success stories than stories that do not go well. And I think that nowadays, with all the tools that we have seen today and all the very good quality information that we have, plus the networks that work of doctors asking each other in the complicated cases, I think that we are seeing more and more successful pregnancies, even those that are very, very, very difficult at the beginning.
Yes.
Well, I think these words are probably the best end to finish this webinar, because these are very folk words. So I think that really things have changed a lot since the very beginning, since the first experience that we, the elderly ones, had in the 80s in managing these patients with the figures that Angela showed before, to now. Certainly for the majority of the cases, there are good therapies, good prophylaxis in order to avoid these problems. So these are the good news to finish this webinar. However, certainly we have still to improve. There is room to improve, and this is our job. And I hope that in the ERN Reconnect, we will collaborate, we will contribute to improve a little bit this. Maybe with new studies that we can perform at the ERN, but also because we spread all this information, all the recommendations to everywhere, to every corner of Europe, So not only in the, let's say, in the top hospitals, research, university hospitals, these therapies will be available, or these innovative therapies will be available, but our aim is to reach every corner, every city, every place, every village in Europe. Thank you again very much, Angela and Silvia, and all the people that attended this webinar, nearly 50. I think that it was one of the most popular webinars, and hope to meet you soon in another webinar or in live. Bye-bye, and enjoy the rest of the day.
Thank you
all so much.
Thank you very much, Silvia.
Thank you. Thank you, Angela. No, thank you so much. Thank you. Bye-bye.
Thank you. Bye-bye. Bye.